morning, everyone. Thanks for joining us. As Dr. Kirkwood said, I am basically the treatment room PA on the second floor over at Hillman, primarily seeing the patients on clinical trials, but also helping out with some of the other issues in the treatment room. So I'm going to give a little talk today called Managing Your Immunotherapy Journey. We're going to go over some of the things you may see during your treatments, and hopefully this will be informative for you. All right, so managing your immunotherapy journey. So just briefly, we're going to talk about what is immunotherapy. The National Cancer Institute defines immunotherapy as a type of cancer therapy that helps your immune system fight cancer. So I think something that's really important for you guys to understand is that this is different from chemotherapy, which is our traditional cancer fighting method that we've used over the years. Now we have this new immunotherapy that initially was with the CTLA-4 inhibitors, which we'll talk about, which we use as Yervoy or ipilimumab. And then we have several PD-1 or PD-L1 inhibitors. Most commonly we do Keytruda or pembrolizumab and nivolumab or Opdivo. Those are the ones that we use the most, but as you'll learn today from some of the other physicians who are speaking, we have lots of new things being studied and worked on for future treatments. So first we want to talk about the PD-1 and PD-L1 inhibitors. As I said before, the pembrolizumab, nivolumab, and cemiplimab are three that have been FDA approved for several different indications. The atezolizumab, avelumab, and durvalumab, those are the PD-L1 inhibitors that are also you may see around as well. Today, mostly I will be discussing issues with the pembrolizumab and the nivolumab. So with these PD-1 and PD-L1 inhibitors, when we talk about, hopefully you can see this graphic to the side, the cancer cells use the PD-1 pathway to hide from your body's T cells. So the cancer cells basically turn on this pathway, and then your body thinks that it is a normal part of your body and it does not fight off the cancer cells. So we've developed these PD-1 and PD-L1 inhibitors to block that pathway so that the cancer cells are visible to your T cells and that your body can fight them. The first actual immunotherapy that we developed for melanoma is the ipilimumab or the Yervoy. That's the CTLA-4 inhibitor. So the CTLA-4 is a pathway that down-regulates the immune system. So when we give the CTLA-4 inhibitor of ipilimumab, it basically takes the brakes off of your T cells, allowing those to increase and fight the cancer as well. So sometimes we use those two drugs in combination, which does have a good efficacy, but also has an increased toxicity. So let's talk about toxicity. So first I want to just give you guys a little background about what we call an adverse event or a side effect. We may say that term to you. So an adverse event is defined by the FDA as any untoward medical occurrence associated with the use of a drug in humans, whether or not it's considered drug related. So if you guys were here last year, I did talk about this a little bit, more in relation to the clinical trials. And we use those adverse events in the clinical trials to help us determine what's related and also how we manage it. So if you're on a clinical trial and you have an adverse event, your protocol has a very specific wording on how we manage that. If you're on a standard of care treatment, you know that those issues have already been studied immensely, and the management is a little bit more physician dependent, we'll say, and so you don't have to follow exact strict guidelines as much, although the physicians are making that basis off of the research that we have done previously. So an adverse event can include any lab abnormality, a subjective complaint such as fatigue or pain, an objective exam finding like abdominal pain, tenderness to palpation, or findings in the lungs, or it can also be something that we see on imaging like pneumonitis, which I have a couple pictures of, which is an inflammation in the lungs, or it could be something like hypophysitis, which would be regarding the pituitary gland, which we can see with a brain MRI. And then I just threw up a little chart, actually I had last year, with kind of an example of how we do the grading. So this one uses anemia, neutropenia, and thrombocytopenia. Anemia would be the low hemoglobin. Neutropenia would be the low neutrophils, which are part of the white blood cell count. And thrombocytopenia would be the low platelets. So you can see on here, you know, grade 1 for the anemia would be a hemoglobin less than 10. A grade 2 is 10 to 8. A grade 3 is less than 8. And typically, from the majority of things, we start getting worried if we have a grade 3 or 4, or if we have a prolonged grade 2. So if we have a grade 2 rash that doesn't respond to our typical treatments, then we would call that a prolonged grade 2, and that may need more strict management. So let's talk about the most common adverse events that we're going to see with your immunotherapy. Now, I want to stress that this can affect any organ system in the body. So I always try to educate my patients before they start their treatments that I'm going to go over the most common things that we see, but it's really important that if you're having anything new, that you call us and let us know, because we will be able to try to, you know, that helps us figure out what's going on. And, you know, even if it's something that we haven't talked about, we want to know about it so we can make sure it's not a side effect from your treatment. So I know this is a lot of words on this slide, but constitutional fatigue is common for everybody. I always try to tell patients some fatigue is normal, but if you're having fatigue where you can't get out of bed for most of the day, that's not normal, and that is something that we need to know about. So we want to look in, we want to work that up, see if we can find any reversible causes of that fatigue. Most commonly would be something like hypothyroidism, the thyroid gland's not working, or adrenal insufficiency, where your adrenal glands are not producing your normal cortisol hormone. Skin issues are very common. We can have itching, rashes, and you can have itching without a rash. You can have sometimes a rash without itching. The severe cases can go on to have blistering or peeling of the skin. And there's also vitiligo and poliosis. I do have some pictures at the end of these. So vitiligo would be a depigmentation of the skin, and poliosis is actually when it affects the hair. And I have a pretty good picture of that affecting the eyebrows and the eyelashes coming up. In the gut, we can see things like diarrhea, which would indicate inflammation in the colon. Black tarry stool can indicate an upper GI bleed, or if we have some bright red blood, we can indicate a lower GI bleed. We can also see mucus in the stool, and those things are often associated with abdominal pain or cramping. Now, I always also try to stress to my patients with the diarrhea that is not just, we don't worry about that just because of electrolyte loss and dehydration, which with the typical chemotherapies we can think about. We worry about that because it, like I said before, it is an inflammation in your colon, which can have severe consequences if it's not treated appropriately. So again, it's very important if you tell us if you're having any diarrhea. In the lungs, you can have shortness of breath or a new or worsening cough, like usually a dry hacking cough. And that can indicate that pneumonitis, that inflammation in the lungs. Liver side effects, so the liver functions can be elevated at times. So side effects of that could typically be nausea or vomiting, right-sided abdominal pain where the liver is, dark urine, yellowing of the skin or eyes. I will add that a lot of times our patients are pretty asymptomatic when they're having elevated liver functions. So that's one of the reasons that we always check those before your treatments, and the labs have to be resulted before you can start your treatment. And then touching again on the endocrine system, so the thyroid gland, the pituitary gland, and the adrenal glands are the ones we most commonly think about. Side effects from those can be fatigue, weight changes, which would be weight gain if the thyroid gland was low, weight loss if the thyroid gland was too high, cold intolerance, constipation, headaches, weakness, hair loss, rapid heartbeat, increased sweating. So you can see this is a long list, and these are just encompassing the most common things that we see. Other less common adverse events which can be affecting the eyes, the mouth, such as mucositis, dry mouth sinus drainage. You can have something called hemolytic anemia, which I've seen a couple times, but is not super common. Usually the white blood cell count is not affected with these types of treatments, but like I said, anything can happen. Heart symptoms, so myocarditis, can be shortness of breath, and irregular heartbeat, chest pain that can affect the nervous system. So that can be several different things: numbness, weakness, confusion, balance problems. The musculoskeletal issues with joint or muscle pain. We have had a couple of patients recently, Dr. Kirkwood and I, dealing with joint and muscle pain. So we definitely do see that, although it doesn't happen as common as some of the other things. The pancreas can be affected, so that can be something like pancreatitis, where you're going to have abdominal pain or pain that radiates into your back, but it also could affect the pancreas's production of insulin. So that can lead to an acquired type 1 diabetes. So symptoms of that would be increased thirst, increased urination, confusion, which would be because of the really high blood sugars. And then the kidneys can be affected as well. So inflammation in the kidneys is called nephritis. That we typically find on labs, but you can see a change in the amount or color of your urine as well. So a couple quick pictures. The pneumonitis, the inflammation in the lungs. Here you'll see a normal chest CT. These white spots or lines you see here, that's all the normal vasculature of your lungs. So this is what it's supposed to look like. And then on the right here, you'll see all this white, much more dense picture. That is the inflammation or the pneumonitis in the lungs. And so every time you get a chest CT, when Melissa or myself or Ashley or any of the docs do your scan reviews, we're not only looking at your cancer, which there's on here, but we're looking to make sure that you don't have any inflammation in the lungs or inflammation in the colon. So these are things that we are looking at every time you get your scan. Here's a couple pictures of rashes. So this one we call it a maculopapular rash, and that just means a macula is like a flat area and a papule is just a little bump. So this is pretty typical. And then this one is more of an eczema picture. So it has this redness here. There's no scaling involved. And these are typically pretty itchy. The rashes, if they're in this category, typically are treated with topical steroid creams. We have different potencies that we can use depending on the severity. And then we also typically like to use oral antihistamines available over the counter. So that would be like your Claritin, Zyrtec, Allegra, Benadryl if needed. And then we actually use Pepcid as well, which is an H2 blocker, which we think of as for your stomach, but that H does stand for histamine. So we use that in conjunction with the other more typical antihistamines to help treat those rashes sometimes. And here's a couple more severe pictures over here. So this one on the left here is a typical psoriatic rash. So we would call this a plaque. It's pretty flat, but just slightly raised. And then you can see it a little bit better here. It has this scaling. So sometimes patients have a history of psoriasis prior to starting their treatments, and these can get worse while they're on treatment. I've also seen them not have a history of it and develop rashes like this as well. And topical antihistamines are typically used for this. And then here is what's a picture of what's called a bullous rash. So this spot right here in the center is fluid filled. And this typically indicates a much more severe reaction. And that can indicate that we need to use oral steroids to help calm this rash down quickly. We don't see these ones very often, but we can certainly. And then here I have a picture of vitiligo and poliosis. So the poliosis is going to be the loss of pigment in the hair. So you can see it on the eyelashes and the eyebrow. It's a little bit difficult to see, but there actually is vitiligo here as well in this patch here, but I have another picture of it on the next slide to help out a little bit more with that. So here's a typical vitiligo from treatment. This typically does not go away when you stop your treatment. So this is a permanent change in your skin. You have to be careful with this because this skin that doesn't have this pigment is going to be much more sun sensitive. So it's always important to wear your sunblock, but even more important in these areas. And then just touching up on the management of AEs that I talked a little bit about before. So again, what our management does depend on the severity. So like I said, those first two rash pictures that I showed you typically can be managed with the topical steroid creams, antihistamines, and then the more severe ones are going to require to hold treatment and administer a steroid taper, that oral steroid taper. And then these couple last slides apply to any time we have to do a steroid taper. So typically we like to use prednisone 1 to 2 milligrams per kilogram per day. So it's weight-based. And then that or equivalent means that sometimes we may use Medrol or dexamethasone or things like other steroids like that, depending on what's going on. The protocols typically recommend that you taper them over at least 4 weeks. And that can be, extended if as we taper your symptoms come back. So we like to taper those slowly for a couple reasons. We want to protect your adrenal glands. So if we give you these high doses of prednisone and then we just take them off, your body's not going to be able to catch up and you're not going to make your normal cortisol levels. Protocol wise, most of them say that we can resume treatment after your adverse event recovers to a grade 0 or 1. Some of them, like pneumonitis, actually require a grade 0, meaning everything's back to normal. So even if you have an asymptomatic finding on a chest CT, they won't allow you to do your treatment. And also, even if the grading is back to 0 or 1, you have to be on less than, sometimes equal to or less than 10 milligrams of prednisone per day. Another thing that's really important is the immunosuppressive agents, so the steroids, don't appear to affect the response to therapy. So if we have to hold your treatment and give you these prednisone taper, it does not indicate that your treatment's going to stop working or things are going to get worse during that time. So that's really important. I know it can be scary to have to stop your treatment, but we have not seen that. All right, so last, what to expect when you come in for your treatment. So you see Dr. Kirkwood in clinic and Melissa and Ashley, and they go over all these side effects and talk about what can happen, but you still have never had treatment before. So on your first day, you'll come in and get seated in the treatment room, get your labs drawn. If you are on a clinical trial, you'll actually have your labs drawn in your research chair. If you are SOC, means standard of care, if you're a standard of care patient not on a clinical trial, you may have your labs drawn in quick draw, then you'll probably go to clinic to see one of the providers and then back to the treatment area for your treatment. So in clinic, you'll get your physical exam, you'll discuss any management of your adverse events. If you have been on topical steroids for your rash, we'll make sure that things aren't getting worse. And review your labs. So once that's all done, you'll come back to the treatment area, the orders will be signed, then they go into pharmacy. The pharmacy will not sign the orders until all the labs are drawn, all the orders are signed, the PE is done. And that, as I have over here, that is to protect you. We want to make sure that it's safe for you to get your drug. We need to make sure that the dose is correct. So we actually have 2 nurses and 2 2 nurses and 2 pharmacists completing these checks to make sure that you are getting the correct drugs. That's super important. We don't want to have anyone getting an incorrect dose or an incorrect drug, because that can have lots of implications. And that is it for me.